Thanks again for the invitation to this year's Renal Research Institute conference. The task that I have today is to discuss with you the topic of preparing the patient for home therapies, what works. These are my disclosures. As mentioned, the objectives I have today is to really review some of the recent trends in home dialysis practice, and also emphasizing on how to overcome barriers to adopt home and personalized dialysis. This particular topic is quite vast, and in this talk I will focus on overcoming specific educational barriers, in particular, focusing on the patients and providers, and also to think about some systems issues. There certainly has been lots of attention on home dialysis. Editorials as well as task force have written about the increase in advancing American Kidney Health Initiative in terms of increasing home dialysis adoption. As everyone's aware, there is a lofty goal of starting patients either on preemptive transplantation as well as home dialysis therapy. We and others have also thought about how to expand utilization of home dialysis in both local, national, and international task forces. Perhaps I should stand back and actually just think about why home dialysis or home hemodialysis, which is my own clinical niche. Clearly, I think and I hope that you would agree with me that by doing home dialysis, there's improvement in quality of life as well as lifestyle. There has been a consistent data and emerging literature to document the cardiovascular risk reduction with more intensive home dialysis. Studies have documented better and improved blood pressure control, also improvement in sleep apnea control, better calcium and phosphate control. Clearly, there's liberalization of diet. We and others have also documented the feasibility of term pregnancy. And using observational design, there's a question about the actual potential of having better survival. However, I would pause in this particular time point to ask people to stop and also think about how we actually approach the patient. Is the patient actually ready when we're talking to him or her about home dialysis? Here is a set of graphs that I took from Kidney 360, focusing on the global differences about home dialysis. As you can see, there are quite a bit of heterogeneity across the globe in terms of the amount of investment, the amount of peritoneal dialysis percentages, and other variety of parameters focusing the actual practice of dialysis. If we look at three countries, Australia, New Zealand, and Canada, often these three countries have been quoted as champions and leaders of home dialysis. And it would be interesting to actually think about some of the practices adopted by these countries and how we might be thinking about implementing these practices and also perhaps emulate some of these practices. I think it's important also to think about patient selection. Oftentimes, home dialysis is thought about after someone is actually started on in-center hemodialysis. I think we at University Health Network have started to think about home dialysis slightly differently for a couple of decades, and that we would consider thinking about home dialysis first to allow someone to start thinking about it as a lack of contraindication. Clearly, probably the most important factor is the ability and the motivation to actually learn about home dialysis. There are few contraindications that are listed on this slide. Having said that, having a mindset of home dialysis first, in my opinion, is probably the most important prerequisite. I think it's also important to have some key patient clinical messages for home dialysis, especially for home hemodialysis, that there's a potential for better outcomes. There's less time actually stolen from the patient, especially when we think about the travels. There's a lot more flexibility in scheduling and also prescriptions, more privacy, better liberalization of diet, and in the era of COVID-19, also better infection control as well. I think it's also important to realize that nothing happens without education. In order for someone to actually pick a therapy, the best way to allow the person to pick this therapy is to educate. Not only to educate the patient, but also educate the patient and the support around the patient. Given the fact that we're all nephrologists, oftentimes we think about our problems quite systematically, just like pre-renal, renal, post-renal. Here, I'm going to break it down into how should we actually enhance the uptake at your home program before someone starting home dialysis, during someone on home dialysis, and after a particular modality of home dialysis, kind of like the pre-renal, renal, post-renal system. So we think about the pre-home dialysis pathway. I think it's important to actually think about how to cultivate that culture of self-care. How do we actually look at chronic kidney disease training as well as care? I think it's also important, and I'm going to highlight some examples in terms of training. How do we individualize training? And have we actually thought about the way that we train? There's lots of interest in transitional care unit or dialysis start unit. And again, what is the actual data surrounding that? I'm going to say a few words about during dialysis and how do we use techniques and strategies to improve the potential of patients' attrition rate. And then finally, home to home as an integrated strategy. The overwhelming theme that actually ties everything together is really the whole notion of assurance. How do we assure training? How do we assure safety? How do we assure knowledge awareness? So let's think about why patients would choose home dialysis or any type of self-care dialysis. Although, as I mentioned previously, clinical advantages have been quoted, I think it's most important for all of us to understand and realize that the perceived advantages that is most crucial from a patient perspective are really three domains. The domains of freedom, better lifestyle, and control. And really these are key from the patient perspective, and it's important for us to understand those and also to maximize those. I think it's also important for us to realize that education is really key in all aspects of care, not only just in the outpatient setting, but also in the inpatient setting. Oftentimes, especially in North America, starting dialysis may be happening as a crash start or as an in-hospital start. Many of times, these patients do not even know that they have kidney problems, and they never even had chronic kidney disease education or clinical care before. So by having an actual in-hospital education program, we have changed this entire notion of starting someone directly from an in-hospital unplanned start to inpatient to in-center hemodialysis. And we started actually seeing that education within the hospital crash start program actually allow 40% of patients going to home dialysis as well. As I mentioned, transitional care units have become more and more popular, both from a design as well as objective perspective, and actually behooves us to actually understand the actual data allowing these transitional care units. To date, there has been mostly case reports and case series documenting these potential positive impact of allowing home dialysis transitions. I think it's also important to actually think about training. If someone is willing to allow the investment of training, how long do we actually train for? This is a table that I took from the Practical Manual of Home Dialysis. You can see that the training is quite heterogeneous. In terms of the weeks or sessions of training, there is quite a bit of variation. It is also interesting to note that the country that has the highest prevalence of home dialysis have the longest training. So it is tempting for us to speculate that the amount of investment that one would do for training may allow us to transition more, shall I say, marginal patients or more challenging patients to actually adopt home dialysis therapy. In fact, if we think about training or training failure, it is interesting to note that about 50% of training failure has to do with medical issues. And here we observed our training failure within Toronto, and 50% of them are medical, as denoted by the surrogate marker of diabetes and comorbidity index. and 50% of them are actually due to psychosocial or socioeconomic factors. For example, not owning your own place. Similarly, using US data, here with DaVita facilities, a 1-year discontinue rate of 24.9%. And again, 50% medical, diabetes being a very important surrogate marker, and then other psychosocial factors were listed as well. I think it's also important for us to start understanding and be more interested in how people learn. We all think that there is a perfect recipe of teaching someone, but in fact, there are different learning preferences that every one of us have. In this particular case, we employ the VARC scale, which stands for visual, auditory, reading, and kinesthetic. And different people have different learning preferences. It is also interesting to see that not only did we classify our patients according to their learning styles, it is also interesting here that visual learners tend to have a different or an advantage in terms of cannulation, as well as an advantage in terms of vascular access outcomes. It is our hypothesis that visual learners may be able to visualize how the cannulation may go, whereas the other patients have a more challenging times. It doesn't mean that we only should pick visual learners, but I think it's also important that we adapt our own training to actually suit the learning style of our patients. In fact, it brings us to this whole overall question: how do we assure home dialysis training? And we have started using different techniques. In this particular case, we started using OSCE exams to test our patients in terms of their awareness, and also to give us feedback to our training nurses. We also have used simulation techniques, and most physicians are quite used to seeing simulation, and other industries have also employed this particular technique as well. For example, flight simulators. And by using simulation teaching, we have been able to show that using simulation, especially in the last week of transitioning to patients to home, we're able to reduce or tended to reduce the need for home dialysis nursing visits after a transition to home. The number of home visits tended to go down, and then the number of retraining sessions or technique failure did not show a difference. It's also important to start understanding the overall technique of home dialysis patients. In this particular paper, we started observing the overall technique in a national cohort, but more importantly and more recently, we started looking at this in a regional way, and also disseminating and distributing these type of figures within our own regional hubs. It's important for us to understand where we each stand, but also to mentor each other to actually allow what might be important strategies that one center may be using to actually improve the overall technique survival rate of your region. Are there other tools that might be able to help? For example, while the person's already on home dialysis, we started, for example, using a vascular access audit every time that a patient comes to their clinic. And by doing a checklist, we identify and also emphasize the importance of looking after your own vascular access. And in fact, we're able to show a correlation between the number of errors that one would make versus the likelihood of having an infection. Moreover, by doing the checklist, we're able to reduce the number of errors that patients may be able to do, and also reduce the amount of infection risk as well. Furthermore, by thinking about this same trend, we use or employ a technique called virtual ward to start supporting our patients at home. In this multi-center cohort, we looked at 4 transitions of care risks. One is right after training. The second one is after a procedure that was done. Third is after a discharge. And fourth is after antibiotics or other type of medications. And by using a standardized call as well as a standardized time to quote unquote round on the patients, we're able to identify different gaps of care. We're also able to allow better patient satisfaction overall. Again, these are very intuitive skills that our home dialysis nursing often are doing already, but by standardizing it and also by implementing it as per protocol, it allows a more systematic and a better delivery of care to all of our patients. I think it's also important to think about education of ourselves. And indeed, this is a recent study that was published in JASN, and 266 fellows responded, and these are fellows that just recently graduated. Which topics would you most like to receive additional instructions in during fellowship? It might not be a surprise to you that the top two topics were indeed home hemodialysis and peritoneal dialysis. So if the physician is not familiar or have gaps in their training about home dialysis, it is no wonder why home dialysis is not often mostly implemented or prescribed after their training. To that aim, we were fortunate enough to partner with Satellite Health and GlomCon to actually think about a pilot use of a virtual physician mentoring project to increase home dialysis knowledge awareness. This is a collaborative effort as a demonstration project. We enrolled 40 physicians at various stages of training, and we have informal as well as formal teaching sessions every other week over a 6-month period. It is interesting to see that the confidence and knowledge awareness, both at baseline and exit, as presented here on this slide, improved in both PD as well as home hemodialysis. Similarly, the actual delivery and dosing of dialysis were also improved at baseline versus exit. The management of complications of peritoneal dialysis also were improved between baseline and exit. And similarly, the management of home hemodialysis issues were also better. We were also fortunate enough to form a project with the National Kidney Foundation to allow us to mentor 2 ESRD networks. And again, similar way to actually deliver this type of mentorship. In this case, not only to physicians, but also to the entire team. I'm here showing you abstract data that we submitted to ASN. Indeed, seeing that across 19 centers, we're able to improve and enhance the median home dialysis rate across 2 ESRD networks. Some of this data have now been published already. At the end here, let me summarize. I think home dialysis is uniquely positioned for growth. And at this point, we have an important alignment both at the systems level, the patient level, as well as the provider level. I hope that I've been able to share with you some of the strategies to implement and also to adopt perhaps in your own local center to help with enhancement in home dialysis adoption and perhaps mitigating some of the attrition. Thank you very much for your attention.